Yeah, this is the most important. Is it working now? I'm talking. Is it working? It's live now. Okay. Okay. Uh, my name is Akram Eraky. I'm one of the residents at Freeman Health System. We will talk today about sepsis and septic shock. Um, so, of course, sepsis is a big thing and one of the leading causes of death in the US is sepsis and septic shock. Um, so the definition of sepsis is it's a life-threatening organ dysfunction uh, caused by bacterial infection in the blood. So if you have bacterial infection in the blood, we call it bacteremia. But if this bacterial infection uh, causes organ damage like kidney injury, liver injury, hypotension. In this case, we call it sepsis. Um, if we give the patient fluid and the patient is still hypotensive, we call it septic shock. So it's very similar, sepsis and septic shock. The only difference is septic shock is persistent hypotension despite giving some fluids. It's very important for us, of course, to recognize if the patient has sepsis or at risk of having sepsis and start giving fluids before coming to the ER. Um, and really, our paramedics are doing a great job by giving fluids to hypotensive patients even before coming to the ER. So if you have infections, this infection will cause a lot of inflammation and inflammatory response, and this will affect the blood vessels, will cause vasodilatation, and the vasodilatation or the dilatation of the blood vessels will cause hypotension, and this hypotension will cause decreased perfusion to a lot of organs like liver, kidney, brain, and this will cause dysfunction or injury to these organs. Uh, so this is the pathophysiology behind it. So again, hypotension will decrease the perfusion and the oxygenation, and this will cause some damage to the organs. And of course, there will be something called lactic acidosis, which means usually our cells use oxygen from the blood. We call this aerobic metabolism. If we don't have enough oxygenation because you have hypotension and hypoperfusion, so the cells will use something called anaerobic um, metabolism, and this will cause the lactic acid in the blood. And it's from its name, it's lactic acid, so it will cause acidosis to the blood. And when you have acidosis, most of the enzymes in your organs will not be able to work. So you will have dysfunction and injury to a lot of organs. Um, so this is the old definitions of sepsis. We don't use this anymore. We don't use severe sepsis, sepsis, septic shock. Right now, we just use sepsis and septic shock. And we already differentiated between um, the definition of sepsis and septic shock. They are very similar. As I mentioned before, the only difference is in septic shock, even after giving some fluids, the patient is still hypotensive. But both of them, you have infection in the bloodstream, and this infection will cause injury to multiple organs and hypoperfusion and hypotension. This is again the definition. So there are many ways to suspect sepsis because when you have a patient with hypotension or shock, this can be anything. This can be cardiogenic shock, it can be hypovolemic shock, because the patient is so dehydrated. It can be septic shock. It can be anything. Like we have different types of shock. It can be something called obstructive shock, which means if you have cardiac tamponade, if you have a lot of blood surrounding the heart, compressing on the heart, we call it cardiac tamponade. We call it like it can cause something called obstructive shock. So not every hypotensive patient has septic shock. So there are different types of shock, and it's very hard when you see the patient just hypotensive to suspect or confirm having sepsis or septic shock without having labs, without having echocardiogram, without taking a look with ultrasound to see the contractility of the heart, to see if it's a cardiogenic shock or not. So we have now some screening tools. So one of the screening tools to differentiate septic shock from the other types of shock is SIRS. We call it SIRS criteria. So in SIRS criteria, if you have 2 out of these 4 criterion, like you can say the patient meets SIRS criteria and I suspect sepsis or septic shock. If the patient has high temperature or low temperature, more than 38 or less than 36, if the heart rate is high, if the patient is tachypneic and the patient is breathing so fast, if the patient has high white blood cell count, if the patient has 2 of these criteria, you can say, oh, I think the patient maybe has sepsis. And it's just a screening tool. You don't use it to like say, I am sure 100% the patient has sepsis or septic shock. Why? Because if you run, if you walk, not run, if you walk so fast, you can have certain criteria. Like if you walk so fast, you can have high heart rate and you will breathe so fast. So you will have a tachycardia and you will have tachypnea. This doesn't mean you have sepsis or septic shock. It just, you had some run. So it's just a screening tool. So keep it in your mind. We just use it as a screening tool. It doesn't confirm the diagnosis. Of course, there are a lot of risk factors to have sepsis or septic shock because all of us can have cellulitis, which means infection in the skin, right? But I can have cellulitis without having sepsis, without having septic shock. But if I have diabetes or cancer or kidney disease, uh, if I am taking steroids or have major surgery or any like things that may affect my immunity, yeah, this infection can easily cause sepsis and septic shock because the bacteria can easily go from the lung or the skin to the bloodstream, and this will cause sepsis and septic shock. But if you are a healthy person, you don't have any like immunologic disease, your immunity is good, you don't have diabetes, it's very rare to have sepsis and septic shock. Of course, if you have trauma, if you have recent hospitalization, if you are very old, all of these are risk factors to have sepsis and septic shock. And the only thing that is common between all of these factors is your immunity is not good. So the infection can easily, if you have pneumonia or lung infection, your infection or bacteria can easily move from the lung or the urine or skin to the bloodstream, and it will cause very severe reaction and hypotension. Of course, as I mentioned, one of the leading causes of hospitalization and death in the United States is sepsis. This is why it's very, very important to recognize or suspect sepsis and start the treatment very early. Of course, those patients initially will be warm to touch. After that, because of like the hypoperfusion, they will be cold. Um, of course, when we have those patients in the ER, we start the sepsis pathway. But before coming to the ER, it's very, very important to give them fluids. Even if those patients are at high risk of having hypervolemia, if those patients have congestive heart failure or end stage renal disease on hemodialysis, it's totally fine to give them some fluids. It's not wrong. Like, and I really appreciate our paramedics. Like, they always, if the patient is hypotensive, they always start fluids before coming to the ER. It's very, very important, because sometimes most of those patients are like fluid responsive. So when you give them fluids, you will correct the hypotension, their blood pressure will improve a little bit, and it's very important to start the treatment very early. So when the patient comes to the ER, we start with CBC, CMP. We check the coagulation in studies, lactic acid, because in septic shock, the lactic acid will be high. We check for some inflammatory biomarkers like procalcitonin. It will be high. If you have bacterial infection, we check, or of course, for the blood gases, the APG or the blood gas, because in septic shock, usually you will have low pH or acidosis. And of course, we order also blood cultures, because in septic patients, we start antibiotics, very strong antibiotics that cover for a lot of bacteria. But after a few days, we will have blood cultures and we will de-escalate. We call it antibiotic de-escalation, which means we start the patient first on very strong antibiotic that cover for everything. But after a few days, when we have the blood culture results, we de-escalate the antibiotics and start another antibiotic that is specific to this bacteria. Of course, urine. It's very important to have urine analysis in septic patients, especially very old patients, because I think it's the most common cause of infection in the old population, having urine infection. X-ray, some of those patients can have pneumonia. Ultrasound, like here, you are just trying to find the source of infection. The source of infection can be urine infection, can be pneumonia, can be gallbladder infection, acute cholecystitis, can be abscess in the abdomen, perforation in the bowel, can be meningitis, can be anything. So you are trying to figure out the source of infection. Of course, the treatment. So according to the sepsis guidelines, it's very important to be a little bit familiar with the sepsis guidelines. So according to the sepsis guidelines, the first line treatment for sepsis is fluid administration. And usually we give 30 milliliter per kilogram. For example, if the patient is, let's say, 100 kilograms, you will give 3 liters of fluids. So we give a lot, and the fluid bolus should be given within the first 3 hours of suspecting sepsis or septic shock. So when EMS give the patient 1 liter or 500, we are happy. That's amazing. Like, we just continue giving the patient more fluids. Of course, if the patient is very obese, like if you have a patient who is 200 kilograms, will you give this patient 6 liters of fluid? Of course not. So usually if the patient less than 100 kilogram, we give 30 milliliter per kilogram. If the patient more than 100 kilograms, we calculate something called ideal body weight. And the ideal body weight usually less than 100 kilogram. So I think the max on fluids is 3 liters. Usually we don't give more than 3 liters within the first 3 hours of suspecting sepsis. After that, also here, again, I will talk about this special population that is at risk of having hypervolemia, which includes patients with ESRD on hemodialysis or patients who have congestive heart failure. So some uh, people will be like afraid to give fluids for CHF patients or patients on hemodialysis because they are hypervolemic or at risk of having hypervolemia, but it's totally fine. In the literature, they support the use of, even in the guidelines, they support to give fluids to those patients even if they are at risk of having hypervolemia, even if they have CHF or if they are on hemodialysis. It's totally fine. Just give some fluids, and you will never hurt the patient if you give 1 liter or half liter. Um, of course, we start antibiotics on those patients. We try to find the source of infection, and sometimes as a source of infection can be treated not only by antibiotics, but also by removing the infected tissue. If the patient has necrotic tissue or abscess or anything like that, you try to remove the source of infection. Uh, After that, if we give the patient fluids and the patient doesn't respond very well to fluids and the patient is still hypotensive, we use some medications to support the blood pressure. We call them vasopressors. Um, so these medications work by causing vasoconstriction to support the blood pressure. Um, so the first line vasopressor is norepi, or what we call Levophed. So Levophed has alpha-1 agonist effect, so it will cause vasoconstriction, it will increase the afterload and the vascular resistance, and this will increase the blood pressure. Also, norepi or Levophed, the other name, um, it has a beta-1 agonist effect, so it will increase the contractility of the heart, and this will increase blood pressure. If Levophed doesn't work, we can start a second vasopressor like vasopressin or vasopressin and epinephrine. If it doesn't work, we add dobutamine. If it doesn't work, we add phenylephrine. Sometimes in the ICU, you can see a patient with septic shock on 3 or 4 pressors. Um, so those patients have very poor prognosis, and they have very high risk of just dying in the hospital uh, if they are on many pressors. Of course, sometimes we add some steroids in the management of sepsis or septic shock, like hydrocortisone or fludrocortisone. So these hormones, we call them permissive hormones because they support the work of pressors. Um, so hydrocortisone itself doesn't improve the blood pressure, but it improves the work of Levophed. Of course, septic shock or sepsis in general can cause a lot of complications, can cause ARDS, acute respiratory distress syndrome, which is lung injury. It can cause renal injury, acute kidney injury. It can cause DIC, coagulopathy. It can cause, because at the end of the day, sepsis is just hypoperfusion. So it will cause decreased perfusion to a lot of organs. So it can cause mesenteric ischemia because there is decreased perfusion to the bowel. It can cause liver injury because there will be decreased perfusion to the liver. It can cause myocardial dysfunction or heart injury because it will decrease the blood supply to the heart muscle itself. So it can cause multiple organ failure. And when you read about the history of sepsis before 2001, the mortality rate for sepsis was like 60-70%, which means every 100 patient with sepsis, uh, 70 or 80 of them will die. And this is like a very high mortality rate. But now, because we start the treatment very early, we try to prevent organ damage very early by supporting the blood pressure very early, giving fluids very, very early within the first 3 hours, giving antibiotics early within the first 6 hours. Um, all of like the new treatments or guidelines decrease the mortality. So I think now it's less than 30%. Yep, that's it. So, do you have any questions about sepsis, septic shock? Oh, we have a lot of time. I can continue talking more about that. Yeah, it's a really very interesting topic. Uh, I published uh, some papers related to sepsis and septic shock recently, and one of the papers I published talking about the use of sodium bicarb in critically ill patients in general, and we discussed the use of sodium bicarb in sepsis and septic shock. It's one of the medications we use sometimes in septic shock and sepsis because those patients will have acidosis and sometimes they have AKI or acute kidney injury, and we try to correct the acidosis by giving them sodium bicarb to improve the pH of the blood. I don't know if you use sodium bicarb in the ambulance sometime. Do you use it only for cardiac arrest or sometimes for septic shock too? Really? Oh, that's interesting. Yeah. So the message from this lecture really is if the patient is hypotensive, start giving fluids. Even if the patient has CHF, it's totally fine. Give fluids. Even if the patient is coming from dialysis center and the patient already hypervolemic with edema, it's totally fine. You can still give fluids. Don't be afraid of giving fluids to those patients, even if they are hypervolemic, since they are already hypotensive. Um, and I don't know, sometimes also I notice you start levofed very early before coming to the ER, which is very good practice, to be honest, because sometimes you give 1 liter or 2 liters and you are still on the road. If the hospital is like 1 hour away or 2 hours away, and you start also levofed very early, uh, which is a good practice. Yeah.
We had Levofed for a while,
Yeah.
and because we don't routinely use pumps, we really don't have pumps. Levofed should probably really deserve to be on a pump.
Yeah.
For the most part, pre-hospital here in this Joplin region has gone to push dose epi.
Really?
So
Just bushes?
yeah.
Oh,
We
then
dilute it down and make it a 1:100,000.
yeah.
And do it in 1 to 2 mics.
Really?
So we get that into being 10 to 20.
Oh, I didn't know that.
Just do that and titrate to blood pressure at a systolic greater than 90. If they're, if they're low. Of course, we want to fill the tank with fluid.
Yeah, of course. This is the first line. Yeah.
So there's kind of that mantra of fill the tank before you squeeze the tank.
Exactly.
So the same concept you just covered here is the fluids. We may not get 3 liters in the ambulance. Or get that started, and then may get a liter, and pressure is still soft, not coming up like we like. We start to squeeze it with epi.
Yeah.
Push dose. Just give small doses. Let it. Then you have to check that frequently and make sure it doesn't start to dive down again. But just giving small bumps of push dose epi.
Yeah, that's nice. Yeah.
We become the pump that way.
Yeah, a little bit. Yeah, small bushes.
Yeah.
Yeah. Yeah, it's very important really to start, as you mentioned, fluids first, and after that you can give like uh, some pressors. Do you have also a neoposh, like phenylephrine? No, just the epi.
Yeah, just happy right now.
Yeah,
The neosepepper has been mentioned, but it was not highly endorsed, I guess, by medical. I think it would be great, honestly.
yeah. Sometimes we use it first before like um, because to get levofit sometimes you in the hospital or in the ER you request it from the pharmacy and it will take a few minutes until we get it. So sometimes we have like a syringe of phenylephrine or neo syringe, and we just push some of it to support the blood pressure until we get the levofit. Yeah.
We could just swing by Walgreens on the way in and get some over-the-counter nasal spray and start do it that way.
Yeah, yeah.
I don't see any questions on here. Plenty of comments.
Yeah.
Yeah.
We've had a lot of great. We've had a lot of good success with push us happy.
Really?
Crews
Yeah.
really like it. Seems to be working well. So
It requires some mixing of what we have on hand to make it happen. That takes care of a few of them a little bit because it's like, oh, I haven't done this in a while, so it's not too hard. So we have to skills lab that sort of thing every so often.
Yeah.
Find them how to do it. Difficult.
Yeah, that's nice. Uh, so really, like right now, the last thing I want to mention is like really sepsis now is like very big area, even in research and in the literature, and they are trying to find like ways to diagnose sepsis and septic shock very early, but it's just very difficult. So they just have a new criteria now other than SIRS. We talked about SIRS criteria. There is a new criteria now called QSOFA, which is a little bit similar. Like if the systolic less than 90 or the patient has altered mental status or something like that, they suspect sepsis. And tachypnea. So it has only 3 criteria, not 4 criteria like SIRS. And they are trying to find ways, but as I mentioned, it's very hard to suspect sepsis. Even in the ER before getting labs, sometimes we just support the blood pressure first, and sometimes we just call it undifferentiated shock because it can be anything. It can be cardiogenic, it can be hypovolemic, it can be anything. So we wait sometimes for the labs, and when we get the labs, we um, and confer and like labs, maybe ultrasound and some imaging, and we confirm it's a sepsis or septic shock. We at that time we say it's septic shock or something like that. Because but sometimes we even don't know like when the patient comes to us if there is no obvious source of infection. Like sometimes we don't know like what is the source of infection. Urine is clear, chest X-ray is clear, the patient doesn't have any source of infection, so we are like, is this really septic shock or maybe cardiogenic shock, maybe something else? Yeah. Any questions? Okay. I hope you enjoyed the lecture.
yeah.
Yeah. Yep.
That microphone.
Oh.
No, thank you. Thank you. This is last year of it.